Welcome everybody to this CARMA webinar by Quinton Grafton from the ANU on high vaccination coverage is required before public health measures can be relaxed and Australia's international border fully reopen. But before we begin, I would like to acknowledge and celebrate the first Australians on whose traditional lands we meet and pay our respects to the elders past and present. My name is Renee Fry-McKibben and I'm a Professor of Economics in CARMA at the ANU. Our speaker today is Quinton Grafton from the ANU. Quinton is an Australian Laureate Fellow and Professor of Economics at the Crawford School of Public Policy, also at the ANU. Since February 2020, he has, including with Tom Compass, who is also on the screen, and other co-authors, modelled and evaluated public policy outcomes associated with different public health measures. I would also like to introduce Warwick McKibben, who is the Director of CARMA, and Joaquim Vespignani, who is Co-Director of the COVID-19 Macro Programme. Before I hand over to Quinton, I'd like to let you know that this event is being recorded and will be available on the CARMA website in the next few days. If you would like to ask a question, please use the Q&A button on Zoom, and I will ask you to either turn on your camera or I will ask the question on your behalf. So over to you. Thank you, Quinton.
Thanks so much, Renee. And I just want to highlight that my co-author and colleague, Tom Compass, will be stepping in as necessary and as he wishes as I go through the presentation. We'll try and do it in 35 minutes. I also want to pay my respect. Here I'm on Ngunnawal Ngambri land, and I pay my respects to their elders, past, present, and emerging. And in particular, I'd also want to highlight in the context of Australia and COVID-19 that there are a number of communities in Australia, particularly in New South Wales. I'll highlight that because of the epidemic underway in New South Wales. They have low vaccination rates. They had very poor access to getting vaccines. And one community I'm familiar with and I've been to is Wilcannia. They currently have, as I understand it, 69 active cases of COVID out of a population of somewhere about 650 to 700. So 10% of the population in this community, in fact, have COVID at the moment. So, you can imagine the numbers in New South Wales would be over 800,000 number of people with COVID at the moment, if that was the same proportion. So we have to be, I think, conscious of the issues associated with COVID across different subpopulations and be aware that that will require a variety of different approaches in terms of public health measures and prioritization. So that's just by way of an introduction and preface. I'll now go and start to share the screen. And I will highlight that my friend and colleague Tom Compass will be coming in as required and as he wishes. So first thing I want to say is that the title is somewhat different to what I provided to Renee last week. It's still the same work. It's not different. So you haven't signed up to something that's different. It's just highlighting, I think, a different set of priorities in terms of how we want to present our results. Second thing I want to highlight is that our work, so you have seen Tom, but there are two other co-authors. That's Dr. Zoe Hyde. She's a public health professional and epidemiologist at the University of Western Australia. And the second person is Dr. John Parslow, who's a mathematician who's based in Hobart. So it's certainly a four-person team, and we've done it in a collective way. So I think particularly for the audience that's outside of Australia, for the audience within Australia, this is probably quite familiar to you, but I think it's worthwhile just highlighting what we're talking about, what our results pertain to. So what we're talking about is there's what's called a national plan or national plan to transition to respond to a COVID-19 pandemic here in Australia. That plan was outlined at the end of July this year in 2021. And it has four phases, a phase A, B, C, and D. Currently, Australia is in phase A, so active suppression of the community transmission. And then we get to phase B, C, and D, and I'll go through that in a little bit more detail in the slide that follows. So I want to be very clear what we're doing in terms of our modeling and our results. We're presenting results in relation to phase D. So we're not at phase D at the moment, we're in phase A, okay? So phase D, and I'll go through the details of what phase D involves, but that's where our results apply. And then the relationship between the national plan that I'm going to give you more detail and our work, the connection is around the adult vaccination rate, because the national plan is based around adult vaccination rates, at least for phase B and phase C. So that's just by way of an introduction. And let me go in now, show you the national plan, explain the national plan, especially for our visitors from overseas in this audience. And you'll get a sense of why I think our work is relevant and I think also valuable. Of course, you can make that judgment as we get to the end of the presentation. So I don't know how well you can read the text. It's very readable in my screen, but you can see the 4 phases: A, current phase, vaccinate, prepare, and pilot. So we just got over that 30% of the adult population in Australia is vaccinated. We have a movement to a vaccination phase, transition phase, and B when we reach 70%. So this is the 70% vaccination target for the adult population, adults defined as 16 years and older. Phase C is when we get to the 80% vaccination rate. Consolidation phase is what they call it. And then you get to phase D, and our modeling results are in relation to phase D. And so let me just go through. You may not be able to read the individual dot points. So phase D is likely to happen. That's not my call, that's the National Cabinet's call, led by the Prime Minister. That's likely to happen in 2022. So it won't happen in 2021, it'll likely to happen in 2022. So dot point, open international borders, quarantine, but only for high risk inbound travel. And then I think the third point is the one that we want to highlight here in the national plan: minimize cases in the community, that's community transmission of COVID, without ongoing restrictions or lockdowns. So basically in phase D, they will remove some key public health measures, and they'll no longer be available, in the sense that the governments who signed on to this have constrained themselves in phase D because of a high vaccination rate. And so the description behind it is to, and I'm reading it now, word for word, manage COVID-19 consistent with public health management of other infectious diseases. Now, the Prime Minister has referred to those other infectious diseases on a number of occasions as the flu, or living like with the flu. So I think that's an indication of what phase D is what it's intended to be, that there will be vaccination, there will be some measures, but those measures certainly will not include lockdowns of the sorts of things that Australia's experienced since March of 2020. Now, before I go on, I want to, and I'll come back to this, and Tom, please feel free to step in, but I just want to highlight for those people who aren't working in the COVID space, and I know it's fairly obvious for those who are, but I just want to highlight it because this is really important. Think of it as a three-legged stool. So I've got 3 fingers up here, okay? So when case numbers, new daily cases, are relatively low, let's say it's less than 100, depends on the jurisdiction, then you have testing or test, trace, isolation and quarantine. So in other words, you do the contact tracing, people are readily identified, they find out who their contacts were, and you do so in a relatively short period of time, certainly within 48 hours. You can get on top of minor outbreaks. So it's just an effective pillar of the public health measures, if you want to include that as a public health activity. But that only works when we have low new daily case numbers. Second is public health measures. Okay, so that's separate to testing, tracing, isolation, and quarantine. And that could really involve just wearing a mask outside or an indoor space. So that's a fairly minimal precautionary type public health measure. Or it could come to a very highly stringent type of lockdown. So the lockdown basically means most people are staying within their household bubble. They're not seeing other people. There are all sorts of restrictions in employment, transportation, mobility, et cetera, et cetera. So that's the second thing. The extreme is the lockdown, but there's a whole range of measures, public health measures. That's the second leg of the stool, so to speak. And then the third leg, which is thanks to all those immunologists and virologists who came up with the vaccines that are available to us. Currently in Australia, there's just 2 vaccines, the Pfizer vaccine and the AstraZeneca vaccine. They're both highly effective vaccines, certainly against severe symptoms and hospitalization. And so that's the third pillar is in terms of vaccination. So what I want to highlight in phase D, as I highlighted in the third point, what is happening in phase D, you're continuing presumably with vaccination, if people are wanting to be vaccinated, you're continuing with testing, tracing, and isolation, quarantine, so long as, of course, new cases are not sufficiently high. And then the third thing is public health measures, it seems, may continue, but they'll only be of the very, I think, low cost form. There certainly won't be any lockdown. So that gives you a sense of where we're at in terms of the national plan. I'm sorry I spent so much time on it. We'll get to results very shortly, but it's important you understand that because there's a lot of confusion, miscommunication, misunderstanding about the national plan. In fact, I heard a premier this morning actually getting confused about the national plan, thinking that some measures in part phase D was in fact in phase C. So it is worth highlighting, and it's useful to look at this document. So the next thing I want to do is to say, when you do the modeling that we've done, you have to make a series of assumptions, as you do with any form of modeling. And there are some key assumptions that we're going to highlight. There are, of course, other assumptions, but I'm going to highlight two key sets of assumptions. One is in relation to what we call case hospitalization rates, or CHR. And the other one is in terms of the infection fatality rate. So both are ratios, and those ratios can be obtained from observation. And indeed, that's what we have done. We haven't actually done it ourselves. That is already published using the information from 2020 and, of course, for 2021 as well. And so we have a series of CHR, case hospitalization rates, and also infection rates, infection fatality rates. And these differ, for those people who are familiar with COVID, or indeed the whole world probably knows this, but they differ, of course, by age cohort. So the older age group, and you can see that quite clearly in these sorts of numbers, the older age cohort are much more vulnerable in terms of hospitalization and also death than the younger age group. So it's a very tiny fraction of the people under the age of 15 who are subject to hospitalization and fatalities, but a surprisingly large proportion for the people who are 80 plus. So you have to account for that in terms of your modeling. You can't just use an average population number. And the other two couple of things I want to highlight. We're using for the results we're presenting today, although we do provide a set of results just as a brief comparison with a case hospitalization rate with the Delta, but all our results in our main text are provided with the original strain. Okay, so that's well observed in a bunch of countries with high levels of community transmission. So we're very confident, certainly for the Wuhan strain or the original strain, that those numbers are robust. It becomes more problematic in relation to Delta. So Delta arrives in the United Kingdom in early April of this year. It was obviously in India and the subcontinent before then, but in terms of good data, in terms of looking at the implications, CHR and IFR, we're starting to get that information now. And so it's just a few months. Preliminary numbers suggest it is more virulent. There's a recent publication in the Lancet just 4 days ago, indicates it's more virulent. The Delta is more virulent than Alpha, Alpha being the UK variant or the Kent variant, which again was more virulent than the Wuhan, the original strain. So that's by way of the assumptions we use, and they come from a range of sources. And then the second set of assumptions that are really important here is the vaccine effectiveness. Okay, so again, fortunately for us, we have this information from a number of countries, including the United Kingdom, United States, Israel, and some other places, and that is now published. So we got a pretty good, reasonable handle on that. So you can see that when we talk about vaccine effectiveness, it needs to be separated into different categories. So when people talk about highly effective vaccines, we have to be clear, well, what are you talking about in terms of infectiousness, or are you talking about symptoms, or are you talking about death? And so you can see, so VE is vaccine effectiveness against infection. The Shadow XA1S is the AstraZeneca vaccine at 60%, that's pretty good. And then Comirnaty is the Pfizer vaccine, the two vaccines available here in Australia. Has a higher level of vaccine effectiveness, at least from infection. Then look at symptomatic disease, 67%, or vis-a-vis 88%. Good in both cases, though Pfizer is better. And then certainly the one that people look at a lot, of course, is hospitalization, which is redefined by severe symptoms. So the idea, if you're hospitalized with COVID, you definitely have severe symptoms. Although it was worth highlighting that people with severe symptoms may not end up in hospital. And some people, of course, do die at home. They don't make it to the hospital. But anyway, hospitalization defines in some sense severe symptoms. Again, a much higher level of effectiveness, which is good. You would want that. And then death, we have that as assumed as the same as hospitalization. There is some uncertainty in relation to that, in relation to the Delta variant. So those are the two series of assumptions based on the published data. Some of it's in preprint or from the Public Health England, and most of it is already published. And so you take those two key sets of assumptions. We have a starting point in terms of the basic reproduction number, which we assume at 6.0 for the Delta strain. So we're focusing here on the Delta strain. This is Australia. And I'll ask Tom to step in. He hasn't talked yet. If you want to step in, Tom, and step in anytime you wish. So go ahead.
Well, so you were doing so well, Quentin, but let me just talk about this slide. Hi, everyone. We use a basic SIR model, standard epi model, which is augmented with vaccination rates to do this sort of work. And Quentin will show you just some of the results. We've got a ton of results here, and we're not going to go through all of them. It says it's a static SIR model, but that's an error from me. It's actually the steady state on a dynamic process that's being fed out. That's important to keep in mind. And it assumes homogeneous mixing. So it's not specific to population types, although there are age classes within the model. The model itself, I'm not going to go through all of this, but it's generally trying to track in steady state comparisons across age classes, the number of infected, that's equation 1, the number of symptomatic, equation 2, the number of hospitalizations, equation 3, and the number of fatalities, equation 4. Again, all as sort of steady state outcomes from this dynamic SIR process. Everything here depends on age class. Everything here depends upon the epi parameters that some of which Quentin just went through. There are in fact other ones as well. And it also depends upon vaccination rates and the type of vaccine that's being used. So there's a lot of complication in that sense. But again, we're just reading out the basic results in terms of these 4 equations for today. I think before I turn back to Quentin, I want to highlight the nature of the counterfactual that we're putting together here when we're generating these results. It's very specific counterfactual. We're in phase D, so nothing before phase D. We're in phase D. So 80% of the adult population's vaccinated. So everyone 16 years and older, 80% are vaccinated. And what we do is we hold that vaccination rate constant now and just ask the question, if that remains constant, what's the effect on these relevant amounts of symptomatic, hospitalized, and fatalities? We also assume, as Plan D sort of suggests, almost explicitly, that there's no additional healthcare measures in place, or at least they're very limited. So no ongoing lockdowns, very little sort of what you would normally think of as social distancing and so on, although some of that may occur. But we're taking a counterfactual where there's no additional health measures. 80% of the adult population is vaccinated, and that remains unchanged. We allow the time horizon to be as long as it needs to be, right? It's a steady state outcome. So it's more than 180 days, in fact, quite more than 180, and we can talk about that later. And then do the steady state comparisons across different age groups, given vaccinations, and given all the things that in fact are being traced here. So it's that kind of model. It's not ABM, it's SIR, relatively basic, but still complicated enough to tell the story that's consistent with what we think of and what the government is saying is phase D in the epidemic. I think back to you, Quentin. I'll chime in again later.
Yeah, thanks, Tom. And so just to reiterate and highlight what Tom just said, so the situation we're talking about in phase D is that eventually everyone gets exposed to COVID-19, okay, or at least the SARS-CoV-2 virus. So why do we say that? Well, because in phase D, the stringent public health measures are not in place. We can see what's been happening in New South Wales. So I think anyone can work this one out, that even if you've got an effective reproduction number now, that is an excessive one, despite an extended lockdown period of time, and an indication that we would get an epidemic, certainly at a state and national level if internal borders were open and international borders were open with seeding. So eventually you were going to get an epidemic throughout the country in phase D. Remember, it's phase D that we're looking at. So it might be sooner or it might be later. Depends on the number of seeding events that we have. It depends on the initial numbers that we start off with. So New South Wales numbers of new daily cases could be. I'm not predicting it. We don't have a model. It's not what I want. But it could be 5,000 new cases a day by the end of this month, for example, end of September. So that's a different case than if you start off with 50, even if you have the same growth rate. So the time period is questionable. What we are asserting, and of course that's to be determined by national cabinet, not us. We are asserting that phase D will arrive in 2022. That's what we are asserting.
Yeah. So indeed, it's thanks for that, Quentin. It's herd immunity across both susceptible population that's not been vaccinated and, of course, those that have been vaccinated. We also assume no waning effect going forward. So after 6 months, the vaccine still is effective as it was 6 months prior. I mean, Scotland and the UK are maybe a good analog at the moment for what phase D might look like and what might be happening.
Yeah, we can get to that at the end, and it's good that Tom's reminded that of us, because you look at the Public Health England numbers or the UK numbers, and you can see, we'll talk to that about, because they're almost at those magic numbers that we have in terms of phase C. So it's worth highlighting what might be coming our way if they take the numbers in the UK, keeping in mind that they also use the same. Though in different ratios, they use Pfizer and AstraZeneca, just like we have in Australia. So we're going to look now at the current vaccination plan. Now, since we put out our work, things have changed a little bit. And so as part of the vaccination rollout, 12, 13, 14, and 15-year-olds will now be included in the vaccination rollout. That wasn't true when we put our work out 8 days ago. So that's a good outcome from the last week. And so what we're going to look at is hospitalizations and fatalities. We can also present the number of infections and also the number of systematic cases. But of course, infections is a higher number, smaller proportion is symptomatic, smaller proportion gets hospitalized, smaller proportion die of the fatalities. And so we take two cases here. So again, this is the current vaccination rollout, with and without vaccinating children. So the dashed line represents the case of excluding children, and the solid lines are including children. Now the blue line represents the line where we prioritize in the context of a vaccination coverage for those 60 years and older. And so we're saying in this case, the people pretty much who got AstraZeneca, that they are vaccinated at a 95% rate. Now, some people have come back to us and said, well, that seems a very high rate. How could you get that? Well, I just point them to the United Kingdom, because that's pretty much where they are at right now. So it's a little not 60, I think it's 65 plus. So clearly it's possible to get there. UK is not the same as Australia, but certainly it's certainly not something mission impossible. So we prioritize that, and then and vis-a-vis having an equal proportion. And it's worth highlighting this because the national plan does not specify vaccination coverage for subpopulations. It doesn't specify it for Aboriginal and Torres Strait Islanders, Australians. It certainly doesn't specify it for older Australians either. It specifies it as the adult population. So the red line here represents an equal proportion across those age cohorts. And so what are the numbers? Well, we're not saying that phase D begins at 70%. It could begin at 80%. There's certainly been implications by one premier of that in the last few days, but we're just simply saying, well, these are the different vaccination rates. You may want to just look at the 70, 80, and 90 or plus, simply because phase B begins at 70, phase C begins at 80. We don't know when phase D begins, presumably at 80 plus, but we don't know what that is. That's to be determined by National Cabinet. But let's take it 70%, we're talking at some well over in a sort of a best case scenario here, in the sense of the most vulnerable are vaccinated at a very high rate. And also kids, and we're getting numbers of around 150,000 hospitalizations, and then at 80%, we're still getting less than 100,000, but a lot of hospitalizations. That's certainly will exceed capacity as far as we are aware in terms of ICU, given most people will be in a difficult situation if they're admitted to hospital. The number that probably is most of interest to many people, not because they're macabre, but they care about lives, is the issue of fatalities. And so, if you take the 70% case, you're talking, depending again on you include kids or don't include kids, but it's somewhere around 29,000 fatalities, not including vaccinating kids. And then at 80%, it's around 25,000 if you're not including kids. So it's good to put that in proportion. So if you're treating it like the flu, so the number of flu cases in Australia is around 1,000 if you take the literature we've looked at. Now that clearly is underreporting. So when I say flu cases, I mean flu cases of fatalities. Okay, so it's almost certainly underreporting. It might be twice that, or possibly 3 times. So you might say that the number of flu fatalities in Australia could be 2,000 to 3,000, although the actual numbers reported would be less than that. So 2,000 to 3,000 is about 1/10 of the eventual fatalities associated with COVID-19 at a 70% and maybe 25 times. It's about 10 times more in the context of 80%. So those are substantial numbers of fatalities relative to treating it like the flu. We can also make comparisons between the current vaccination strategy and the strategy that we've highlighted in our scenarios, so that the alternative strategy is ensuring that boosters are provided to those who receive the AstraZeneca vaccine. And why boosters? Well, Tom already highlighted the issue of waning immunity in relation to Pfizer. That's also appears to be the case in AstraZeneca, but maybe not as rapid. But in particular, you saw the assumptions we made, which is based on the observations, namely that the vaccine effectiveness of Pfizer, at least in the initial period of time, is more effective than AstraZeneca. So if you give a booster, you can increase the vaccine effectiveness, and so that provides benefits, certainly on a population health basis. The second thing we do in that strategy is we can vaccinate kids. And the third thing we can do, and we'll consider that as well, is have a higher vaccination target for the older age cohort, those aged 60 years and older. And so we can compare the AZ mRNA, which is the AstraZeneca mRNA, that's the current vaccination rollout, with which is in blue, with the red lines, which is the alternative scenario that we have modeled. And you can see that providing the boosters, having the additional vaccinating kids, and having the vaccinating at a higher rate with 95% provides benefits, but you can still see that there are still substantial numbers associated with hospitalizations, although less than what we saw previously. And it's also worth highlighting here that there's this magic number here, and Tom mentioned about herd immunity. So herd immunity is going to arise when everyone either has been infected and recovered, or has been vaccinated. And we find that it's certainly possible to get herd immunity in Australia, though it's certainly a big ask. 95% of the population would need to be vaccinated, but it's certainly a possibility. So we certainly have that in there. That's why this goes to 0 at 95%. And then you can see the fatalities associated with the different strategies, and you can see the booster strategy that's in red. The mRNA does save a bunch of lives. And of course, the other thing to highlight is those lines are, of course, going down. So the higher the vaccination target you set, or all else equal, you are going to get lower levels of hospitalization and fatalities. So if you have your goal at 80%, even in the best case scenario, you're getting a little over 13,000 fatalities. That's best case. That's not the current vaccination strategy. You go to 90%, you get to 5,000. So you can save 7,000 or 8,000 lives by going from the 80 to 90%. So that's pretty clear, pretty obvious, I think, but it's worth highlighting. Then what we do is quantify those numbers. And then the last thing we can do before we start to talk about some of the economics behind that is to give you some notion that the CHR, the case hospitalization rate, and the IFR, the infection fatality rate, that we've assumed make a big difference. So it's an important set of assumptions. And we assumed that those numbers came from the original strain, okay, from 2020. If we take preliminary numbers, estimates for Delta, again, remember, we don't start getting good data from that until April, okay, or later, okay, from the United Kingdom. Okay, we do have some now data in Australia, of course, from the New South Wales epidemic. But anyway, let's go through that, and you can see that from comparison to the original strain, those numbers are much, much higher. So and we're not saying we know that, we're just saying if the virulence is higher with Delta, it's certainly much more transmissible. But if the virulence is much higher, and there's now, as I said, increasing evidence suggests that it is, you have much, much higher rates of hospitalization, into many hundreds of thousands at 70%, 200,000, even at 80%. So those are large numbers of hospitalizations. And then the fatalities, of course, are also substantially higher as well. So again, we don't know the world that is the Delta world, but we have two sets of results to provide that information to everybody. And then the last thing is to look at the implications for the different age cohorts. So these just represent the percentages within each age cohort. And so the percentages are associated, these are the percentages on the y-axis, the vertical axis. These are the age cohorts that we've examined, and the different colors represent the different vaccination rates. All right, so the percentage, so this is the scenario we're assuming is the standard vaccination scenario that's been outlined by National Cabinet, but children are not vaccinated. And you can see relatively small proportions here of hospitalization, in fact, very small proportions of hospitalization. But nevertheless, when you have 5 million people, children in that age category, although the numbers are small, they're not zero either. And of course, the bigger age classes and the more vulnerable ones take a bigger hit. And then this clearly is even more shown in terms of fatalities. There will be some fatalities in our modeling in relation to young kids. There will be, but the number is so small we don't see it here in the graph. And of course, the 80+ group are the ones that will dominate in terms of fatalities. It's worth highlighting, and we do have a figure for this, it's worth highlighting that when you see this, you don't just assume that these people are silly elderly people who've chosen not to be vaccinated. Okay, it's very clear that there are vaccination breakthroughs. And so I'm not a public health person, but if you take the sort of a rule of thumb that I've been told by public health professionals is that you take double vaccination and you will reduce your risk relative to someone who's unvaccinated, maybe 25 years younger than you are. So if you're 85, you're double vaccinated, your risk of severe symptoms from COVID may be the same as an unvaccinated 60-year-old. Okay, so that gives you some sense that despite the fact that people are vaccinated at a high rate in the elderly category, I'm talking 80+, nevertheless, there will be people dying associated with COVID-19 under the assumption, of course, the phase D, everybody at some point or other gets exposed to COVID-19. So these are not just unvaccinated people, a lot of these are vaccinated people. And so just to close up and talk through to key recommendations, but I just want to highlight, you can do a bit of, thanks Tom, go ahead.
I just want to emphasize that what Quinton's presented is what's being peer reviewed now. So what you're about to see is work that's in a sense preliminary, and we still have to work on it further. I just wanted to make that point before you look at the economics.
Yeah, so thank you for highlighting that, Tom. So we just wanted to say, because there has been statements out there that one statement, for example, says that once you reach 70% of the adult vaccination coverage, then the cost of lockdowns are not worth it, that you need to stop. So that's been stated more than once by a political leader in Australia. So we want to just do some back of the envelope. I call these back of the envelope calculations. So take them with you as you will, but how we calculate them is perfectly transparent, just as how we calculated our hospitalizations and fatalities are perfectly transparent. You can replicate what we've done. There's no need to go and become an agent-based model or get a code. I mean, it's very easy to do. So you know, that makes it easy, I think, for everybody to understand what we've done. So all we've done is gone into the Australian Treasury report that has complemented the Doherty Institute public health modelling. And so Treasury came up with 4 different contexts in terms of lockdown at a national scale, and the most stringent or strict is $3.2 billion a week as the cost. That's pretty much where we are right now, actually, with lockdown in Victoria and New South Wales. It's got to be around $3 billion. So that's almost worst case scenario, but that certainly is a possibility, and Treasury certainly has that. Then a moderate, low, and then baseline. Treasury also looked at a set of numbers as well, assuming that once you reach certain vaccination rates, that you wouldn't need to go to those more stringent levels of lockdown, which is consistent with the national plan, as the implied by the national plan, certainly with statements by a number of political leaders. And so I provided those numbers here. So 50 to 60%, it's 2.7 billion a week. If you're having a national lockdown, it doesn't mean that you would, but if you did, well, so if it's 80% plus, it's down to $590 million a week. It seems so the numbers now with COVID, it's always billions, so when you see anything less than $1 billion, it looks trivial, doesn't it? But we mustn't keep the pre-COVID, pre-pandemic thinking, $1 billion, something in hundreds of millions is still non-trivial. Anyway, so those are the numbers we use. That's straight out in the Australian Treasury. And so all we did is just simply calculated, very simply, benefit cost ratios. And of course, to do that, to calculate the benefit, we have to look at avoided hospitalizations, avoided fatalities, which is the biggest benefit associated with a higher vaccination rate. And we didn't calculate the avoided hospitalizations, although we can do. We've done that in previous modeling. We just did a very simple calculation associated with the value of a statistical life, which according to the Prime Minister's office is $5 million per life. And we discounted that because as we've shown to you, a lot of those fatalities will be in the older age group. And so some of the literature has discounted that. So we discounted it at 70% of what the 5 million is. So and then we compared the difference between the going from 80% to 90%, the number of people whose lives would be saved if you went for a higher vaccination target. And did so under the assumption that there was national lockdown throughout the period of that going from 80 to 90%. And we assumed that period was 3 months. So I think those are reasonable. I'm not saying that would be the case, but those are, it can be debated, but those I think are reasonable and certainly transparent assumptions. So you look at the benefits, the avoided fatalities, it's obviously 70 billion each case. And then you look at the cost of waiting, that extra 12 weeks. And you can see the benefit cost ratio. Now, keep in mind, we don't take into account mental health costs or other costs associated with lockdown, but also we don't take into account the costs of long COVID. So long COVID seems to affect those who exhibit symptoms. It seems to affect maybe 5% of those who become symptomatic. And of those 5 to 10%, there is a proportion that end up with quite severe, what they call long COVID, which is the most severe. Some of them are life-threatening, but post-viral fatigue, for example, is a particularly nasty aspect of long COVID. So we don't count for that either in productivity losses. So this is a very simple back of the envelope calculation. But again, it suggests to us that in fact there is a benefit, and the benefit exceeds the costs of increasing your vaccination rate from 70 to 80% or 80 to 90% in this case, and taking the time to do so. Although again, we can dispute the assumptions behind that, but we just did it because that's the discourse out there in the last week. So we said, well, why not do some numbers? And no one else has done that yet, so why not do it? So we've done it for you. And so I'm just going to close up now, and why don't you talk to the key findings, Tom? I've done a lot of the talking, and then we'll go and do key recommendations. So those are the 3 key findings.
Yeah, I think it's pretty straightforward. I think you did really well, Quentin. You can see that if you have a vaccination target of 80% of Australians greater than 16, and you transition, if you, in a sense, too quickly without vaccinating more people, and again, remember that's what our counterfactual shows, then you can end up with quite a few hospitalizations and fatalities. If you can reduce that, you can reduce those, in fact, if you follow a different kind of procedure, one that we outline in the work that implies 90% vaccination, and also coverage of children, and 95% coverage in those age 60 years and over with an mRNA booster. I mean, that's important. Someone asked in the chat box, do we model the impact of having AZ in people over 60 relative to not having Pfizer? Not directly. We're sensitive to that issue. I'm especially sensitive to it. But what we do is introduce a vaccine booster, an mRNA vaccine booster for those who've had AstraZeneca prior. You get considerable savings, and the benefit cost ratio, given those back of the envelope calculations, can be quite large. So in our mind, it's an argument for sort of waiting a little bit longer, vaccinating more people, and deferring a lot of mortalities and morbidities as a result.
Thanks, Tom. And of course, we want to highlight it's not our call, it's not our decision, it's the decision of the National Cabinet.
Yeah.
But we think this is useful for National Cabinet in terms of their dialogue and debate about this, because Phase D, remember that there is no target for Phase D in terms of vaccination coverage. So we think this is part of the discussion that needs to be part of what National Cabinet does.
And indeed, we're just reading off a basic SIR model, and that's what we got.
That's right.
That's important to highlight.
That's right. So it's our political leadership that needs to make the call, not us. We're not suggesting we should, but we obviously giving you a set of results that I think are useful in that debate. The other thing that's probably worth highlighting, because it only came out yesterday, so I put it in last night in terms of the slide deck. And so this is the Guardian Australia Essential Poll, and it looks really at the issue of acceptable deaths. And it is relevant, of course, to what we've just talked about in terms of cumulative or eventual fatalities. And there's a surprising number of Australians at the moment who would consider a number of deaths in excess of 5,000 to be unacceptable. Now, remember, there's no trade-off here. They just simply said, what's unacceptable to you? Well, only 3% said that 5,000 deaths or more is acceptable. So 97%, at least in that poll, respondents said no, they wouldn't be good enough, wouldn't be acceptable to them. So again, that I think is just like our modeling and our results, that's a useful thing to keep in mind when decisions are being made about vaccination coverage and the public health measures associated with Phase D. So nothing more than just simply saying that I don't think many Australians, and perhaps you are better informed of the audience today, are aware of what's coming in terms of fatalities at some point or other. If we get to Phase D, if we have vaccination coverage, for example, at 80%, we've given you those numbers, and there are the options to have much lower numbers with higher vaccination coverage. And so let me just close with the key recommendations. Remember, the national plan has these 4 phases, and those phases are all governed by or conditioned on vaccination coverage. And it's about living with the virus. Now, we think that is back to front. Okay, so the way this should happen is, and I again won't be surprised to this well-informed audience, but the way a strategy should operate is as follows. I don't believe it will happen, but we're certainly arguing that it should. So national cabinet, not us, not Tom, not Zoe, not John, our co-authors, need to determine what that maximal tolerable level of morbidity or hospitalization and mortality is, as well as long COVID, because it is an important issue. So national cabinet determines what that is. It's not for me to determine. Is it 5,000, 10,000? Is it 50,000 fatalities? And then they make that call. They're our leaders. They're elected into those positions of authority and responsibility. And then go work backwards from that to work out what are the minimum vaccination levels and the public health measures that would give you, and a reasonable, obviously it's a risk analysis as well, that would give you a reasonable chance of not exceeding those maximal tolerable levels. Okay, so you'd have the three-legged stool. You'd use all three legs of that stool. Vaccinations, of course, public health measures, and ideally TTIQ, testing, tracing, and isolation, quarantine, to be able to,
for low numbers.
To get to whatever that, to avoid that threshold. And it's not zero, okay? So you can see in our modeling, it's clearly not zero. The fatalities in Australia will be in the thousands, okay? That's coming eventually. Depending, of course, unless we get to a herd immunity, if we get to that holy grail, so to speak, that will be a different situation. But certainly under the proposed 80% at phase C, it would be in the many thousands. And then provide the necessary trade-offs. We did a very back of the envelope trade-off in the economics, the benefit cost ratio. We've done a trade-off in the context of the extra time involved. We looked at the trade-off in the context of a different strategy, as in vaccinating kids, higher proportion of the subpopulation, the elderly, those sorts of things. So those are the sorts of things that would need to be done, I think, in a much more thorough, transparent way and provided to the general public. And that's, from our perspective, is what a robust strategy, national plan should be. Every country should have one. Be honest, be transparent, and then work through how we avoid that crossing that threshold. And I want to highlight that it's not zero. We're not talking about zero fatalities, okay? So there will be fatalities. It's a question of what national cabinet considers to be the number that it considers acceptable or tolerable. So that concludes our presentation, and very happy for questions. I'm sure Tom will answer, and I will answer as well as best as we can. Thank you. Shall I get out of the screen share?
Yes, please.
Yeah.
Thank you, Quentin and Tom. We have a few questions already. If anyone else would like to ask some questions, please put them into the Q&A box. Our first question is from Jeff Houghton, and he says, given capacity constraints of the health systems, I think he's referring to the ICUs, can we differentiate within hospitalizations in and outside of the ICU?
Yes, we can. We've done that in previous work, but we didn't do it in terms of our presentation. So yes, so we know ICU a number of beds, we know the number of hospital beds, and there's some ability to have what's called surge capacity, and that's related to not only beds but also to staffing arrangements. So if there's there is an epidemic right now in New South Wales. So there's the potential, therefore, as hospitals fill up, that you can transfer people to hospitals across the state or possibly interstate. And of course, there's the possibility of staff going into, let's say, New South Wales. But there's only a little bit of capacity there, and again, there's a question of how that gets done. But so yes, there's an ability to surge, but the implication of that surge needs to be clear as well. Again, I can't give you the full details if that was the question, but the implication, of course, is when hospitals get full with COVID patients, all right, it means that people who are seeking medical attention for a variety of ailments, surgery, cancer treatment, whatever it might be, they're not getting that treatment, okay? Certainly not elective surgery. So there's a whole cascade of effects associated with that. So it's not just a COVID impact. There's an impact associated with people have delayed delayed health treatment, et cetera, et cetera. So yeah, so it's clearly an issue. We've seen it last week in Sydney with a couple of hospitals. The vice president of the AMA, I think, has made some statements about that. How people won't be allowed to be admitted to hospital who are non-COVID patients, and they would have to get some sort of treatment at home, keeping in mind that would almost certainly be inferior to hospital. So if you're being admitted to, people don't get admitted to hospital unless they have a need to be admitted. So if they're not admitted then and they're at home, they're not almost certainly not going to get the same level of attention as they would in hospital.
We also have a question from Andres Sirianta, who says that some research shows that natural COVID antibodies from infection wane within 6 to 9 months, and probably even faster against the Delta variant. How would this affect your modelling?
Well, there's two sets of issues here. So both AstraZeneca and Pfizer, there does appear, and this is very recent evidence. Okay, we're not talking 6 months ago. We're talking the last 2 months. Evidence, particularly from Israel, but it's also being demonstrated in other countries, that there is waning immunity associated with both vaccines, possibly more with Pfizer, and it is also connected to age as well. There may be a relationship to age, so the older you are, the immunity wanes at a faster rate. There's also evidence as well from 2020 that people who did get COVID with the original strain have got reinfected, and there are multiple cases of that in the United Kingdom. And so, yes, there is a waning immunity associated with that as well. There's some new evidence that's come out about the SARS-CoV-1 virus that, of course, was out in 2003, that people who did get that, which is a much more virulent virus, who did survive that, recovered from those infections, do apparently have a good immunity to SARS-CoV-2 virus. So that's encouraging, but yes, the answer is yes, there is waning immunity. The implications from our results is that we said that there would be boosters. Now, clearly boosters are not going to be available to the Australians until 2022 because we don't have enough supply, particularly of mRNA, and that's the one supply we don't have and in sufficient numbers. So we won't be providing boosters to people until, everyone has been vaccinated or have the opportunity to be vaccinated. And indeed, there are 1B priority people who haven't been vaccinated. So, we wouldn't be providing boosters, I don't think, unless all those people have received have been fully vaccinated. But so that's 2022, and we certainly included that. I don't know whether, Tom, you want to add to that?
I just wanted to say we didn't model the effect of not having boosters in terms of waning rates. It certainly would extend the horizon over which the model would converge, but we just haven't done that.
Timo Henkel has asked a question in the chat. Isn't the 80% threshold partly based on an assessment that the remaining X% of the population do not want to get vaccinated? So if the maximum tolerable levels of morbidity and mortality require, say, a vaccination rate of 90%, then this discussion needs to include other measures, for example, compulsory vaccination.
Yeah, so there's a whole literature on compulsory vaccinations and mandated vaccinations. It's not always successful as it appears to be for a variety of reasons. Yes, so Timo's question is well taken in the sense of, well, what is possible vis-a-vis what is modeled. And again, I would point to the United Kingdom. I'm not saying that we're like the UK in any precise way, but it is worth looking at the UK. So at the moment, for adults at 16 years and older in the United Kingdom, 88%, I think, have received one dose, at least one dose, and 79% have received 2 doses. And the elderly population in the United Kingdom have received, I think, at 94%. So it's certainly those sorts of numbers suggest that 90% is as a stretch, but it's not impossible. There are jurisdictions in Australia that have achieved, in fact, have achieved 95%. Lord Howe Island, as I understand, has 95% vaccination coverage. Certain communities have received that sort of coverage. So it requires not only supply, it requires accessibility, it requires communication, it requires a whole series of things. But the point is well taken. There will be Australians who will refuse to be vaccinated. Okay, so there's no question about that. How many there are, we can't say. We do know that the vaccine hesitancy has declined in New South Wales, in the sense that there's a bunch of people now signing up to get AstraZeneca. That's a very sensible thing to do. It's a good decision, because if you can't get Pfizer and you're in an epidemic, you definitely want to have an effective vaccine, which of course AstraZeneca is, in your arm. So we'll keep in mind, I think as more Pfizer becomes available, given the miscommunication that's gone on about ATAGI's statements and restatements and miscommunication from people who don't quite understand what ATAGI actually said, that I think will also assist in increasing the coverage once Pfizer and of course Moderna is coming on, and then Novavax is another vaccine that's coming in 2022, or certainly. So yeah, a big ask. 90% is a big ask. I'm not, no doubt about it, but I don't think it's impossible. And certainly from the United Kingdom, I would think we can do better than 80%. And again, why wouldn't you aim for that? Yes, there's costs associated with it, extra time involved to get you to the higher vaccination rate, but why wouldn't you go for it? I mean, it's again, it's this cost-benefit trade-off, which we've looked in a very back-of-the-envelope way, suggests that there is a big payoff. Obviously, you're not going to wait 3 years necessarily, but certainly waiting an extra few weeks or 3 months in the back of the envelope suggests that it has a high payoff, at least giving it a go.
Joachim, you had some questions?
Yes, I have one question. If I understand well, when you are using the mortality rate and hospitalization rate, etc., you are just taking groups of 10 years thing. And it appears to be the case that, for example, I can see it here in front of me, that data from the Australian Bureau of Statistics that show that, for example, between 80 and 84 and 85 and 89, the distribution is quite different in terms of mortality. And I don't know if there is data for vaccinations or how effective are in these groups, inside this group, basically, because it seems to be the case that by breaking into 5 years, at least 2 or 3 of these big categories, the one that is between 70 and 90 in particular, I mean 70, 80 and 80 and 19, we could get much better, more accurate results if we can. I'm not sure if the data exists, but that's my question.
Tom stuck his hand up, otherwise I'll
so this is a really good question. Unfortunately, the data we have, I think, well, the best data we have has vaccination effectiveness by these decades. So it would be very hard to calibrate without that data by 5-year sort of increments. You're quite right. Mortality varies within a decade substantially, but we don't know how to compare it to vaccination effectiveness within a decade.
But can you approximate with the mortality rate by the groups that is not related to the virus? Because that is kind of an indication of comorbidities, if you want.
Yeah, sure. So there's a whole excess death argument here as well, right? That's relevant, but we've not done that.
Warwick?
Yeah, thanks very much, Quentin and Tom. That was a really interesting and very important presentation. I had 2 questions. One was, what is the main difference between what you've been doing and what the Doherty Institute has given to National Cabinet? Or maybe we don't know, but are you using the same sort of modelling? Are you using the same sort of assumptions? Second question is, how important is it the fact that you're working with steady states rather than transitions? Because I would think there'd be a different dynamic when you're modelling the transition. Maybe you need ABMs for that. But a third question is, your recommendation is perfectly sensible, how you do the analysis. Yeah. Our political leaders say they're listening to public health experts. Why aren't they following what would be seen to be sensible public health advice to actually do these calculations before pushing for these adjustments, which potentially have very high economic and social costs?
Yeah. I think that last question also relates to Elizabeth Cowan's question that she has in the chat.
That's perhaps the hardest question of all, Warwick. Why do politicians make certain decisions that on the surface of it, don't seem to be wise decisions. I'll let the audience to work that one out. That's not just a COVID question. That applies to taxes. It applies to a whole range of decision making. Although in the context of COVID, of course, we're talking about the potential loss of thousands of lives by making the wrong call. So it clearly does matter even more. So the issue is what Doherty Institute did in terms of its modeling vis-a-vis our modeling. There are a number of key differences. So the Doherty Institute only provided results up to 180 days. Okay, so if you want to look at their figure 3.3, for example, or look at several of their scenarios, they have multiple scenarios, you can see that the number of cases haven't peaked at 180 days. So when they summarize the number of hospitalizations and fatalities, it's obviously an underestimate of the actual number because if it hasn't peaked, it's clearly going to go on beyond 180 days. We don't get some miracle happening at 180 days. So that's one difference.
Well, you have an election actually at 180 days, coincidentally, but
yeah. Well, the other one is the assumptions they made in relation to symptomatic cases associated with those who were infected. They have different assumptions to us. The lower numbers, quite low numbers, in fact, doesn't seem to be, doesn't seem from our assumptions, but different. TTIQ, yeah.
Yeah. So some of that modeling in Doherty is not about phase D, right? It's about other phases where there there are lockdown measures in place. I mean, I don't think our work really is a direct comment, other than what Quinton said on the Doherty work. It's trying to model phase D more explicitly. I would just add that point. And I'd also say too that the dynamics does matter, Warwick, and we are working on that because you get some overshoot sort of effects that happen here in the dynamics. But that's work that's pending. For now, we're just going to keep it simple and just look at the steady state outcomes.
Yeah, but I think there were three questions. I tried
to avoid
there was
that
a second
other one.
question, wasn't there, Mark? I don't try to hide. So what was there was a question.
No, Tom just got at the dynamics, working at dynamics versus steady state.
Okay, good. Thank you.
It does matter.
Yeah.
Okay, we just have one last question from Larry Liu. Does the benefit cost analysis assume that the vaccines are effective and safe? Many game theoretical models of voluntary vaccination often take into account adverse health risk of vaccination. Have you considered any costs associated with such risks?
Well, not in the benefit cost ratios. I mean, the number of people who will get adverse reactions in a very serious way associated with, let's say, AstraZeneca or Pfizer. So we're talking 1 in 38,000. Those numbers are trivial compared to the fatalities that we presented. In the context of Pfizer, it may be 1 in 500,000 vaccinations. So, I mean, there are a very, very small number of people who will have very severe adverse reactions, but it's tiny. It doesn't count essentially in the context of our models. That it's just nothing. It does count, and I think that's where the question's coming from, in the relation to vaccine hesitancy or maybe anti-vaxxers. But I think we're talking about hesitancy here, not people who are committed to anti-vaxxers, but people who are hesitant because they're concerned about their own personal health associated with vaccination. Again, all I can say is there was unfortunate communication the last few months about the vaccines, and I think that's contributed. And I would say that the epidemic that we have in New South Wales has contributed to a lot of people signing up to get AstraZeneca as the only thing available to them, to a number of people in New South Wales. So that has changed. And I think that dynamic will continue as we go forward. As the epidemic, if it continues in New South Wales, which it appears to be, or if it expands elsewhere in other jurisdictions, I think you'd probably get a bigger take up than you currently have. And then the second issue is the Pfizer. Most people, it appears to be concerned about AstraZeneca. And so if Pfizer were available, which it will be in adequate supply soon, not yet, soon, then you'd imagine people would sign up for a Pfizer who are hesitant about AstraZeneca because of some miscommunication that's happened over the last few months.
We just have one last, sorry, go ahead.
Yeah, sorry, I was going to just say the bigger impacts that we're leaving out, or the the sort of mental health issues, the loss in productivity with homeschooling, all the things that people suffer through. Those things aren't included in that back of the envelope benefit cost ratio, and they're relevant.
Yeah, and neither is long COVID either.
Yeah, long COVID. Yeah, another one. Sorry.
I just have one quick last follow-up from Elizabeth Cowan about how is your work getting before our decision makers and their advisors?
Say that again about decision makers, sorry.
How is your work getting before the decision makers and their advisors?
Oh, well, I took 2 hours on Monday night to send a personal email with attachments to every premier.
Yeah. So we get the message out. We get the message out. We're on social media. We're doing other things that need to be done. Again, remember there are a number of competing models out there, and I might just close from my side with this point. The Burnett Institute model has mortality numbers that are roughly comparable, and also the Grattan Institute model has mortality numbers that are roughly comparable. We're a little higher than both of those, I think. Isn't that right, Quentin? But these aren't results that should be like, they're out there already. We're just adding to the conversation.
Yeah. The other thing too, and Tom mentioned this earlier, and I did as well. If you doubt models, and not that would be the case for this audience, because a calmer audience will, of course, do understand the value of models, of course. But I have found in discussions, certainly on social media, people just sort of dismiss models as some sort of waste of time. So when they do that, and I have these conversations with them occasionally, I just point them to the United Kingdom, and I say, well, go to the UK and look at what's happening in the UK. That's not a model result. That's in-time, real observation of what is happening in number of cases, 250,000 cases in the last 7 days, approximately 700 deaths, approximately 6,000 new hospital admissions. Okay, so do the math on that. Obviously, the population is not the same as Australia, different demographic. Keep in mind they've lost 135,000 approximately already to COVID. But you can do the math and the proportions of population. Just give you some raw back of the envelope numbers. Just if you don't believe our numbers or other models, and you get some sense of what those number of fatalities are going to be per day once this goes. And it's worth highlighting. I'm going to highlight this again because it's a key point that Tom said, must highlight this. So there are three legs to this stool. Okay, now in the United Kingdom, because those case numbers are so high, the TTIQ, testing, tracing, and isolation, quarantine, it's gone. It's essentially gone. And by the time you get contacted, it's too late. I mean, if you've been infected, you're already infectious and you've infected someone else, so that's gone. Public health measures, well, they had Freedom Day. We're not supposedly having Freedom Day in Australia, thank God. Hopefully not, but it's not. Hopefully it's not announced or unannounced Freedom Day. But the UK definitely had a Freedom Day, and that meant that public health measures, most of those public health measures are gone. There still are some, okay, but most of those are gone. So two legs of that stool are gone. So there's only one leg left, and that's vaccination. And if you base it on vaccination, you can see the implications. I've given you those numbers. 250,000 identified cases in the past week, 6,000 or so new hospitalizations in the past week, and approximately 700 fatalities. So, if that's the case where you've only got the one leg of the stool. We in Australia, okay, and we're economists and modelers, but public health people, epidemiologists who know this better than we do, are saying exactly that. You want the three legs. You want the TTIQ, you want the public health measures, and of course vaccination. Working together, you get a better outcome than if you try and just use one. And so that is the concern that we would have, and how we think the national plan can be improved is to make sure we use that combination of those three legs to get a better set of outcomes for Australia. And it's not mission impossible. It can certainly be done. We just need to do it.
Okay, well, thank you. I think we're running over time now. So thank you so much, Quentin and Tom, for presenting your work to us and for your modelling. And thank you, audience, to all the great questions that you've had. So please join me in thanking Quintin and Tom for their excellent presentation.
Thank you.
Thank you very much.
Thanks, Tom.
Thank you.
Thanks, Joaquin. Thanks,
Thank you.
Warren.
Thanks,
Thank you, Renee.
Great work. Keep it up.
Great work.
Thanks.
Okay.
Mhm.